Hello, everyone. I'm Dr. Ashraf Abdelghani, Director of Research at CANN, the International Cancer Advocacy Network. It's our pleasure to welcome you to today's webinar on the 340B program. We are delighted to have over 150 participants joining us today from across the country. Please note that this webinar is being recorded and it will be made available after the webinar. And now I would like to turn it over to our moderator, Dr. Robert Popovian. Thank you.
Good afternoon, everyone. My name is Robert Popovian. I am with the founder of Conquest Advisors, as well as I'm a visiting fellow at the Pioneer Institute. The Pioneer Institute is a think tank based in Boston, Massachusetts. I'm also the Chief Science Policy Officer at the Global Healthy Living Foundation. I welcome everyone to this webinar discussing the 340B program with multiple perspectives that we have as panelists. We have a great panel participants that are going to be able to share their views about the 340B program and where we go from here. Just to give you some perspective from ours, the Pioneer Institute has been studying the 340B policy issue from both the federal and state level for the last 3 to 4 years, even longer. And we have a tool that is available on our website at thepioneerinstitute.org. And it's 340B abuse. All of the data within our website is from HRSA, the organization within HHS that manages the 340B program, or from the RAND Institute regarding charity care. Everybody's welcome to go to the website. There's a lot of information in there. We're just going to update, actually, I just sent a note that we're going to update the one-pagers for each state. We have it up, but they're older data. We have just updated them. So you're more than welcome to go in there. Just a few comments about the 340B program before we get to our panelists. 340B program is a great program. It's something that I have benefited myself as a practitioner when I was in residency in Los Angeles County, USC in the mid-90s. It was a hospital that 90 to 95% of patients walking through the doors were uninsured, and the 340B program was a godsend for us to keep our doors open. Unfortunately, since then, the program has gone off the rails somewhat. It's grown significantly. It's the second largest drug program in the US. It's going to be the largest, probably bypass Medicare relatively soon here. Not only that, the growth has been despite we in the United States having fewer uninsured patients. You know, there's been significant Medicaid expansion through ACA. And at the same time, with the ACA, there's been a significant expansion of covered entities and contract pharmacies. And those are the things that we're going to be talking about. The other thing that is very obvious is that since the inception of ACA, there's been a precipitous drop in charity care, especially among 340B hospitals. And if you go to our website on Pioneer, you will learn more about that. So without further ado, I'm going to turn it over to our panelists. We have a great panel set up for you to learn more about this program. And if you guys have any questions, we're going to keep all the questions to the end, and I'm going to moderate the questions. If you have any questions, if you're listening to this podcast, watching this webinar, please put it in the chat format, and I will be monitoring that and taking a look at it, and we'll ask the questions. Please identify yourself if you're interested and your organization, just for us to have a better idea where the question is coming from. But without further ado, I'm going to turn over to Nick Ferreyros from the Community Oncology Alliance. Welcome. Nick and I have been on panels multiple times, so we've heard each other talk quite a bit, but he's going to kick it off for us. And Nick, I'm going to turn it over to you. I know you don't have any slides, but you have a lot to say about this program. Your organization has been involved significantly on this topic. So
yeah, thanks, Robert, and thanks for having us. And just to level set, so who is COA? The Community Oncology Alliance, we represent independent cancer practices such as Kathy's at Pontchartrain. These are non-hospital based, usually physician-owned cancer centers across the country. We deliver the majority of cancer care in the United States. and do so at low cost, high quality, and in an accessible environment that's close to where patients live and work. So, I truly believe it when I say that it is the backbone of the U.S. cancer care system, and we really heavily relied upon for providing that care. So I've been at COA for about 10 years, and every single day of that time, I've been talking about 340B. And 340B is, as Robert said, a very critical program. I want to level set there and say, none of what we advocate for is getting rid of the program or removing it from what it should be doing, which is helping patients who are un or underinsured access critical care that they need, including cancer care. However, whenever I talk about 340B, I talk about it in terms of what's called the vicious cycle. I call it a vicious cycle. That this is a program that was meant to help vulnerable patients get access to their needed medication, but what it has become is essentially an ATM or a cash cow for some large mega hospitals, and has completely morphed it into a profit engine for them. And now, in the last few years, they're PBM partners. You may hear about pharmacy benefit managers, or PBMs. That has become a really big part of the 340B story as well. And so this vicious cycle that I talk about, you have these institutions, not all of them, but a good number of them in recent years, that exploit the program. They expand, they consolidate care in their regional marketplaces. The majority of Americans do not have competitive healthcare markets. They're markets that are dominated by single large hospital institutions and health systems. And when that happens, you have sort of, any basic economist will tell you you lose competition. And then when that happens, they become a market taker. They can ask for whatever prices they want. So these hospitals take the 340B program and all the dollars that it brings to them. That gives them a competitive leg up in the healthcare marketplace. They use that to expand and consolidate and vertically integrate in their marketplaces. They gain more and more control. And then what happens after that? The cycle continues. It drives up costs for all of us. There are lots of studies out there that in recent years that have looked at the impact of 340B driven consolidation on expenses, everything from your lower employee work to increased health benefit costs. And that drives up distortions, that deepens sort of the monopolistic power of the players involved. And then it raises costs for all of us. When a patient is treated at a 340B institution, those drugs are not given to them at a discounted price. They're marked up. Those of us with employer-sponsored insurance, which is the majority of Americans, then pay on that bigger ticket, that bigger sticker price. And so the vicious cycle continues. It then feeds. Those profits then go back into the hospital. They go and continue consolidating and strengthening their place in the line and taking over the system. Now, I say some mega hospitals and health systems, not all of them. And part of the problem in what we've seen, and Robert sort of started to tee up over Medicaid expansion and health system changes. The last 2 decades ago, we were on the cusp of the Medicare Modernization Act, and about 15 years ago, you had the Affordable Care Act. And so you've had all these major changes along the way to our healthcare system and the structures of it. And that has allowed this program to grow significantly from what it was in 1992 for just a handful of small critical access hospitals to now you have the majority of hospitals in the United States are quote unquote not for profit and participate in this program. And they do so by gaming the system and gaming the stats. They gain eligibility by getting an off-campus satellite facility that it may be in a poorer area. They gain 340B access in the program. They get through 340B, they get to buy drugs at extremely low 50 to 60% discounts. Then they sell that back to the patients at the full price. And so what ends up happening is patients are paying more on the sticker full price. The employers who pay for health benefits pay more on that. We're all paying more for that. The hospitals are retaining the money, And it's very clear. A study just came out last week that showed that in the first 5 years of joining the 340B program, the uncompensated charity care that these profits are supposed to be funding actually decreased by about 22%. So it is not going direct. The hospitals will claim that they need this program to benefit their patients and give back to the system, but that's not always the case. Additionally, if you follow the dollars, most of that money is being reinvested into the stock portfolios, bond portfolios of these hospitals, not patient care. It is not being invested into increased staffing and increased services. Then, probably more egregiously, and this is research that we've done at COA, if you're a cancer patient and you go to a 340B institution, the drugs you are seeing are marked up 3 to 11 times. The profit margins here, we're talking about an institution making, hundreds of thousands of dollars on your cancer treatment on drugs that they bought at an extremely low discount. Many of these institutions are pocketing this money, not reinvesting it, as I talked about. And that means that we all collectively, as a community, as a taxpayer, as employed individuals who pay our health insurance, and when we see these numbers go up and up and every year, that correlates with growth in 340B. And last but not least, and the original reason that the Community Oncology Alliance got into 340B is because it fuels acquisitions. When a community oncology practice, and Kathy will talk a little bit about this in a bit, when a community oncology practice is operating in a marketplace where a hospital is gaining significant profit margins from the 340B program, they are then sort of pressured into joining that hospital system, either by choice or by force. And that is because a 340B hospital that can take out its competition and gain more cancer care and more revenue from that cancer care, that's just pure profits, pure dollars. And so what you've seen over the last 2 decades is this tremendous energy from hospitals to try to dominate their cancer care markets and service lines in those markets, so that then they can gain more and more profit and revenue from the program. So that consolidation means less choice for patients. It means less access, more difficult. Oftentimes satellite clinics, or if your local provider gets bought up by a hospital, that institution, then that location sometimes will get swallowed up, and you'll have to drive farther distances for your cancer treatments. Last but not least, I know I said last earlier, but you have the pharmacy benefit manager angle on it. Now, most 340B institutions have what are known as contract pharmacy relationships. And that means that they contract with a pharmacy to provide pharmacy services to their patients. What has happened over the last few years is that pharmacy benefit managers, or PBMs, have realized that there's tremendous profit to be made off of this program. And so they have built up those contract pharmacy relationships with the hospitals. And there are some estimates that up to 25% of the dollars in 340B that flow through these relationships are being retained by the pharmacy benefit managers. That means that a government program that is meant to support nonprofit healthcare institutions taking care of indigent patients, that money, up to 25% of the dollars that are flowing through those pharmacy relationships, are going to for-profit pharmacy benefit manager intermediaries. And these are not small companies. This is the Fortune 6 company in the United States, the CVS Caremark, and that is not driven by them selling toothbrushes. That is driven by them being a pharmacy benefit manager. So hopefully, I've helped sort of paint a little bit of a picture as to why we at COA care about this. And I think later on we'll get into some of the reform ideas that we have.
Nick, thank you so much. And I want to put a pin on that PBM issue, because I make the same argument with pharmacies. I say the longer you let this program grow and grow and grow, what's going to do, it's going to drive out the community pharmacies, because what happens is you're making the rich richer and they end up buying them out. And if nobody believes that, go read the FTC report that came out. It's very clearly points out what's going on in that space. So put a pin in it, because we want to come back to it. The other thing I want to mention is that I had a radio interview this morning in Illinois, and I made the comment that Cook County Hospital, which has half the revenue of Rush Memorial. Rush Memorial in Illinois has 413 contract pharmacies. Cook County has 1. So how can an institution half as large, it's not as large as Rush Memorial, but from a revenue standpoint, can manage everything through one contract pharmacy, while Cook County needs to have 413 of them. So there's a lot of stuff that we need to talk about. But I'm going to go to Kathy now. Kathy and I have known each other a long time. Kathy Oubre. She's the CEO of the Pontchartrain Cancer Center, one of the organizations that Nick represents through COA. And Kathy, you and I have talked about it, but you can give the perspective of an organizational level of a community oncology organization who's competing against these larger hospitals. And I want you to comment a little bit about what's going on in your world on this topic.
Sure, happy to. Good afternoon, everyone. Thank you for having me today. So, as Robert and Nick said in the beginning, just to level set, the 340B program is a very good program in its original intent, and no one is, advocating for the total dismantle of the program. However, it was intended to help safety net hospitals stretch federal resources and help, more patients. But what has inadvertently happened is it's contributed to the closure of community oncology practices all across the nation, including in Louisiana, which results in just a severe competitive imbalance in our ecosystem. And as Nick alluded to earlier, this is caused primarily because the program enables hospitals to purchase these medications at significant discounts, and that creates a financial disadvantage a financial advantage because they can compete much more aggressively with organizations such as Pontchartrain, and we simply don't have access to those same discounts. So this disparity in pricing can lead to community practices struggling to compete, potentially resulting in closures of the organization or acquisitions by hospitals. And to put a finer point to it, in Louisiana, when Pontchartrain was founded back in 2005, there were over 30 community oncology practices within the state. And as of, this year, there are less than 5 of us. And in the 3 markets that we have practices in, we are the sole community oncology practice within all 3 of those markets. And to put a finer point to it, everyone, in our most rural market, that community hospital is not a 340B facility, nor does it have an infusion center. So if something were to happen to Pontchartrain, it is a 45-minute drive in every direction to the next, community oncology center, actually, which would be us in a different market, or a 340B entity. And as I mentioned, that's our most rural area. So those patients will immediately have access issues. And that's something that we think about a lot when we were opening that location and as we continue to provide patient care to it. So we were talking about, 340B and the impact in the competitive landscape to the practice, but what does it mean to the patient? So as a result of these acquisitions and practice closures, you do have more patients that will then consequently be funneled into those hospital outpatient departments where treatments are substantially higher. There are multiple studies over the years that have shown that patients pay more in out-of-pocket costs for the same chemo, when they're treated at a hospital outpatient setting versus a community oncology setting. And to put a little bit of a finer point to it, there was a study that Milliman did back in 23 that showed that cost sharing for these infused drugs is on average 34 to 54% higher in hospital settings than in community oncology. This, by trickle down economics, will increase financial toxicity for patients and even disrupt or delay care if the patient simply cannot pay for that. And I do want to call out, the 340B program also can impact a state's budget. So most of us are aware of, the 2024 North Carolina Treasurer's Report that came out last year. And it specifically looked at the impact of 340B on the state health plan. And what, the treasurer concluded was that 340B hospitals in North Carolina marked up their drugs on average of about 5 to 6 times more than what they were purchasing it for. And that correlated to about an 84% increase over what the non-340B hospitals were charging. So that means that some 340B hospitals in the state of North Carolina were charging over 12 times the cost. So, for example, one Keytruda treatment could yield a profit of over $13,000 for that hospital setting. And getting back to the patient, because it really is all about the patient. Similar to the New York Times story about Bon Secours in Richmond, that North Carolina Treasurer's Report also found that these 340B hospitals and their contract pharmacies tended to expand into the wealthier zip codes, the more well-insured areas, as they were minimizing care or extracting care from lower income communities, which we have seen in Louisiana as well, all in an effort to maximize profits in the 340B program. And, these are not isolated stories or events. If you talk to most community oncology organizations or the residents in that area, most communities do have their own, Bon Secours story. Do you want me to go into the state action yet, Robert, or do you want to?
Well, the Bon Secours is a great example because I just put it on LinkedIn a couple of days ago that one of the satellite hospitals used the revenue from 340B to buy naming rights at a local baseball field, which is not charity care. So we have a question actually in the chat we'll get to about charity care and the requirements. So yeah, talk about Bon Secours. That's a perfect example of an organization that's being investigated currently by the feds about the way that they've done it. And it came out about a few years ago in a New York Times article. So go ahead, Kat.
Well, I mean, the New York Times, everyone read that Bon Secours story and, our hearts just broke for Richmond. But it is not isolated. We see that here in Louisiana. We see that here in my own communities. I was mentioning to another group recently that even in my largest market, at the time, 10 years ago, there were 3 community oncology organizations. And over that time, that's changed to just us. And those other 2 practices have since moved to the hospital, and they served the lower socioeconomic residents of this particular parish that we sit in, which is a county to you guys. And so now the driving distance for those people, and by the way, those pharmacies have since kind of moved out of those markets as well. It's at least a 20-minute drive. And in St. Tammany Parish, there is no public transportation system. So it is either having your own transportation, finding a friend or a family member, but we don't have public transportation in our communities, nor do we have reliable Oubre. So immediately we are seeing these same, resources move from, the most vulnerable patients into the wealthier zip codes. St. Tammany Parish, which, houses the practice I'm sitting in today, we are the wealthiest zip code in the entire state of Louisiana. But yet we have a very large 340B entity just 5 miles from this practice. So there's that. And, The interesting thing is, and so I'll segue for a minute, why have states started stepping in when this is, a 340B is a federal program. So why are the states stepping in? And that's something people ask me a lot. And the way I kind of explain it and think about it is with federal action being so slow, the states have become these laboratories, for better or for worse, for 340B reform. So since 2024, 17 states have introduced legislation targeting 340B issues, whether that's contract pharmacy access, transparency, or in sometimes talking about site neutral payments. And altogether, over 100 bills were introduced, in the 2025 legislative cycle, which I thought was really interesting. But in absence of true, meaningful federal 340B reform, the states, quite frankly, are taking it into their own hands as a way to safeguard against program abuse, helping to ensure that savings actually reach patients, and to enhance oversight. So I'll throw it back to you, Robert.
Thank you, Kathy. And you're absolutely right. I mean, the states are going to take action when the feds are not doing anything. So we can talk about it because there's some good bills out there that the states are doing the right thing. In fact, I testified on Monday in Massachusetts Senate Bill 848, which is a transparency bill. It basically forces the 340B entities, the hospitals, to report how much revenue they're getting in and how much revenue they're putting out in regards to charity care and what that charity care looks like. So it's a starting point. Minnesota, Indiana have passed similar laws. And we will go back, talk about a little bit about Minnesota and the Cassidy report, because Senator Cassidy's report, because that's important for context of how much money are we talking about regarding margins, specifically to these contract pharmacies, and why the pharmacies that are lining up, the PBM pharmacies, and Nick was really nice about it. I think it's more than 25%, frankly, when you add CVS, which is the largest. Why they're lining up to sign up for this 340B program. It's very lucrative business for them. So without further ado, I'm going to turn it over to Dr. Erin or Arnold. We decided to have an actual practitioner on the panel, to talk about, she's representing the Coalition of State Rheumatology organizations, but it's good to hear from a practitioner because you're probably feeling it from patients that come to you to get treatment, and then why they're being sort of forced into this, going to a certain pharmacy because of what we will talk about, these contract levels and the thing we need to talk about it. I'm hoping that Kalvin will talk about it eventually, is that at the end of the day, patients don't benefit. Whatever pharmacy they go to, their out-of-pocket cost is not impacted. It's the institution that forces them to go to certain pharmacies. And Kalvin will talk about it later on. But Erin, welcome aboard. I know you have some slides. Do you want to share them or do you want to talk? How do you want to do it?
I think they're a teeny bit repetitive because so many people have already said so many very interesting things and have, but sometimes maybe just looking at them can also reinforce for people that are on the call today some of the things we've been talking about. I am a private practice rheumatologist and I have my own practice. I'm in the northern suburbs of Chicago. So like Kathy, this practice is in a much more affluent area. We are surrounded by 340B institutions, whether they are community-based hospitals or outreach hospitals from some of our bigger academic institutions in the city. And we do see this impacting our patients directly. Ashraf, do you want to throw up the slides and then I can just move through them quickly, or I can prompt you to say when to move on?
Yes, the screen, you can see it right now.
Yep, it's perfect. Thank you. So again, I sit on the board of directors for the Coalition of State Rheumatology Organizations, and have also been trying to really launch an advocacy chair for our Chicago Rheumatism Society, which is supposed to represent all of Illinois. And Illinois is our legislators are pretty open to hearing our ideas about PBMs, about 340B, so I can share some of that. Nothing has actually passed our legislature with the 340B, although Pritzker just did put something into place with PBMs. But I meet often and have people to my office all of the time. I will tell you that it is fitting that I'm on this call with oncologists because that's really the group that we have followed the closest in rheumatology. In the last 20 years, we've seen 70 it used to be 30% of rheumatologists practiced in large hospital environments, whether they were academic institutions or community-based hospitals. And now that number is 70%. And like people have alluded to, the most concerning thing about that movement is that we know that care is more expensive when it's in a large facility, a hospital-based facility, and we also know that it's less efficient. And we're seeing that increasingly as we see even more of our rheumatologists retire. So we have a huge workforce shortage as well. Just to reemphasize, and I think people are quoting numbers from 5 to 11% higher, our concerns are that like everyone has said, this drives consolidation. I think the number is as high as 80% of the, I had something written down here, in fact, that the 340B hospitals are responsible for approximately 80% of hospital acquisitions. And we're seeing that just across the board in rheumatology, that they are able to charge, again, 6 to 11 times kind of more than we are. We actually have patients who have to get their infusions in the hospital, and we have them bring their ABNs to us so that we can share this with local politicians to help them understand what's actually happening in our community. If you could skip to the next slide, please. I think this is helpful just for people to see. We've heard the last two speakers kind of walk through this. This just to me is like I respond very nicely to pictures. But this just kind of shows you how the money moves. I think there are two really important things to point out here. And this example here with the patient is actually a patient who has commercial insurance. So you can see that the patient is still responsible, even though the drug was purchased at a significantly discounted rate, that the patient is still responsible for their cost sharing, which can be a sizable amount of money. And again, you can see the amount, like almost a 34% markup, and all of how lucrative this is for hospital systems. I think that there are finite resources that are available in healthcare, and increasingly we are going to see that with all the cuts that are headed our way. And I just think that, again, if you're in private practice, the infusion center and profitability in the infusion center used to be what helped us to support the remainder of the practice. And that's how these hospitals are using it, right? To support their advertisements for the Super Bowl and their bigger buildings that they're building. But for us, from a competition standpoint, if we can't get access to drugs at cheaper prices as we drive down the reimbursement for these medications, this becomes something that no longer can support the practice. And then our patients have to be finding a new place to be taken care of. So I think this just very nicely in a picture form spells out what everyone has already said on the call. If you could just move on to the next page. This is my plug for advocacy. So I am a perfect example, one rheumatologist in the Chicagoland area. Because of my affiliation with CSRO and CRS, I wind up being kind of the contact person that speaks to a lot of our local representatives and also tries to put things out there in our local print. And it's really amazing to me how impactful this can be. So as the 340B was being looked at in Illinois, and I think some of the plan was to actually expand 340B, we were able to, through this and kind of a campaign we did, stall that out in our House of Representatives. In the Senate, it actually did pass, but wound up getting sidelined in the House. So again, very interesting. And then if you could just go on to the last slide. So again, like everyone has said, I don't think any of us think that this shouldn't be used in the appropriate way and the way it was fashioned to be used. I think that, again, the center of this has to be the patient. And frankly, for the patients to be healthy and for the patients to have access to care, the physicians have to be whole and have to be able to make their practices work. And so I think when you look at what all of healthcare is supposed to center around, which is the doctor or the provider and the patient relationship and supporting that, the 340B program now and the loopholes that crafty people have discovered are really just costing the system more and not serving the patients that are supposed to be served. We're looking for oversight and transparency and accountability. CSRO has posted 60 letters across 19 states kind of expressing our concerns with current legislation that's being proposed and how the program is being abused now, pointing out all the loopholes. We're specifically concerned about some of the unfettered expansion that we're seeing in the contract pharmacies. And I can give a personal example of that when appropriate for everyone, of a experience we just had with a union who's basically making a patient and penalizing them if they don't get their medicine through a 340B hospital. That's an outpatient medication, so it's an outpatient pharmacy. So I'm going to leave it there. I think a lot of what I said is what people have also mentioned, but we're seeing that in rheumatology, we're seeing it in gastroenterology. And, you know, unique in rheumatology is that we're a small workforce and we have a tremendous number of patients and not the people to take care of them. So if you keep driving people out of practice or consolidating into these bigger, less efficient systems, we're going to run into big problems.
And Erin, you mentioned something that is very interesting. The money is in the brand products, right? That's where the margins are the best. So they're going to come after specialists and physicians who still there's a lot of brand pharmaceutical presence in the marketplace, right? It's not going to be your primary care physicians who prescribe primarily generic drugs to manage patient care. It's going to be the specialists such as rheumatologists, oncologists, you know, that are in that space. So great having you, because it's always good to hear from an actual practitioner in these panels. Now we're going to pivot and have somebody who represents consumers. From the National Consumers League, we have Lisa Bercu.
Perfect.
Is that right? Good.
That's perfect.
Welcome, Lisa. We generally don't hear from consumers because, you know, everybody assumes this 340B program is sort of like, you know, it's all about the hospitals and it's all about physicians and pharmaceutical industry, but the consumers get also impacted by the growth of this 340B program. So please go ahead, take it over and tell us what the consumers think about it.
Yeah, absolutely. Thank you so much for having me today. So today I'm going to talk to you about a big campaign we're doing within the National Consumers League about 340B and medical debt. So just to give you a little bit of background about us, we're the nation's pioneering consumer and worker advocacy organization. We engage in a number of issues beyond healthcare, including food safety, child labor, and privacy. Within healthcare, a lot of our work is really focused on access to healthcare, drug affordability, which is the issues, you know, that we're talking about today as it comes to 340B. Safe medication use is a big issue for us. We have a campaign called Script Your Future, where we work on medication adherence and partner with student pharmacists and other healthcare professionals across the country to try to increase medication adherence within their own communities. And then advocating for science-based policies. So things like vaccine confidence is a really big issue for us right now. So just turning to 340B specifically, this is reiterating many of the points that you've already heard today, which we're very much aligned with, which is really that we support the original intent of 340B, but that the savings just aren't being passed on to patients, and that hospitals, these pharmacies, and PBMs are pocketing those drug discounts and not passing it on to patients. And so we think reforms are needed. I think it sounds like we'll talk a little bit more about reforms later, but we want to make sure that 340B actually benefits those low income and uninsured patients that it was intended to benefit, that we're prohibiting aggressive debt collection practices, and I'll talk about that a little bit more in coming slides, and that there's really more transparency across the board. So in terms of medical debt, this is an issue that has long been of a concern within NCL. We did an analysis, and here we'll send my slides along, we'll share them, but we did an analysis which found that 340B hospitals approach medical debt collection much more aggressively than non-340B hospitals. So we found that 68% of 340B hospitals have denied or deferred care to patients who have pre-existing medical debt, in comparison to 37% of non-340B hospitals. And then 86% of 340B hospitals have taken legal action against patients, in comparison to 68% of non-340B hospitals. So you can really see the types of aggressive actions that are being taken against patients who come in for care and they incur medical debt. We also did a national survey of 20,000 Americans on medical debt and just their perspectives on 340B generally. And what we uncovered is that there's really overwhelming concern about medical debt and a strong public demand for reforming the 340B program. So we found that medical debt is impacted a majority of adults. 25% currently have medical debt and 29% previously had medical debt. And so as such, there's just really strong support for policies to tackle medical debt. So some of the policies we floated that have strong support include requiring providers to offer payment plans, and as I mentioned earlier, prohibiting the denial of care due to pre-existing medical debt. We also found that familiarity with 340B is really low. Under 10% of people that we surveyed were actually familiar with the program. But once we presented just a neutral definition of 340B, they really liked the idea of it. But once we also mentioned some of the critiques of the program, they did not like those abuses and they were really concerned about those. And so ultimately, we found that 79% thought that 340B should be reforming of the program should be a top priority for lawmakers. We also released 50 state fact sheets, which are linked to here, which break down that national data at the state level. And so you can see where people within your state fall in our surveys, on what they think of the 340B program. And if you meet with members of Congress or people within your states, this could be information you should feel free to pass along, because it's publicly available on our website. In terms of federal advocacy, we're urging Congress to advance reforms to bring more transparency, accountability, and oversight to the program. Right now, we are engaging in a really big grassroots campaign. So we've had over 130,000 constituent letters sent to members of Congress. And we are focusing on those champions right now to identify patient stories that we can use to highlight abuses. So for example, if they've come across surprise costs in their medical bills, if they have been subject to aggressive debt collection practices by their hospitals, those are things we're uncovering to help our efforts to highlight some of the abuses. We developed a handout to educate congressional offices, and we also did some influence ads to target key congressional offices, just to make everybody aware of what the 340B program is and some of the critiques and abuses going on in it. And then finally, we developed an educational website. It houses most of the material that I've mentioned today and the links that I've included here today, and a video which just very nicely summarizes the 340B program. And then the last thing I'll land on is an opinion piece by our CEO, Sally Greenberg, which I think very nicely summarizes what's going on, which is that 340B was designed to help low-income and uninsured patients access their medications, but it's morphed into a financial bonanza for hospitals and chain pharmacies, while patients in need aren't getting the benefits of those discounts. So thank you very much, and I look forward to the rest of the discussion.
Thank you, Lisa. It was great. We always need to hear the consumer's point of view on this, but I want to pivot now to Kalvin. Patient perspective. Kalvin, I've heard you talk passionately about this issue in multiple state hearings, and let's get your perspective on this, and then we can start with questions. And I see some folks have already put in some questions in the chat box, so we'll get to those as soon as we're done with Kalvin's presentation.
Good afternoon, everyone. I want to thank everyone at the International Cancer Advocacy Network for having me on this important panel. My name is Kalvin Pugh, and I serve as the Director of State 340B Policy for Community Access National Network. And more importantly for this conversation, I'm a patient who has benefited from the proper use of the 340B drug program. It's CANN's mission to define, promote, and improve access to healthcare services and support for people living with HIV and AIDS and/or viral hepatitis through advocacy, education, and networking. Now, normally you get the pleasure of having CANN CEO Jen Laws here to speak with you, but anyone who's engaged in 340B at the state level will tell you that we're all tired. He's on a much needed vacation, and I, however, am fueled by a lot of coffee and Botox. The 340B program has been discussed at length here, but I want to highlight the legislative intent, which is to stretch scarce federal resources as far as possible to reach more eligible patients and provide more comprehensive services. Today, it poses a significant risk of exacerbating existing healthcare challenges rather than effectively addressing the critical healthcare needs of underserved patients, burdened by rising medical costs and debilitating medical debt. Instead of serving as a supportive measure for low-income and uninsured patients, the program has evolved into a tool that primarily benefits entities by generating revenue with limited accountability for the use of those funds. The abuse of 340B program is so well documented that it has been outlined in a recent report from Chairman Bill Cassidy of the Senate Health, Education, and Labor and Pensions Committee, which requested a comprehensive understanding of where dollars generated in this program flow and how such revenue benefits patients. The information gathered included letters requesting information and data from hospital-covered entities, health centers, large for-profit pharmacies, and pharmaceutical manufacturers. Throughout the last 7 months, we have seen 33 state houses put forth and in some cases enact legislation that has created a patchwork of state-level laws at odds with the original intent of the 340B program. As opposed to 19 states in 2024 who put forth such laws. These laws, often masquerading as protecting the 340B program for patients, capitalize on the lack of limitations at the contract pharmacy rules of the original legislation. To increase profits for covered entities, PBMs, and for-profit chains, the truth is that these legislative efforts truly only protect the profiteering hands of the 340B cookie jar. In contrast, only 16 states have put forth legislation requiring reporting from covered entities for their use of the program. Many of these states have been unsuccessful in enacting these transparency and accountability measures, often facing opposition by hospital associations and misled provider associations, often placed before lawmakers who stand the most to lose if transparency were to be required. What I always ask is why transparency and accountability have become such dirty words when it comes to 340B. Abuse is rampant and well documented. It seems that every other day there's a new news story regarding how this program, intended to allow the underserved access, is being commandeered by greedy CEOs and for-profit entities. The Ryan White Drug AIDS Assistance Program serves as an exemplary model in the 340B space and is the only named grantee. They are obligated to provide comprehensive coverage to an entire state through their contracts. Additionally, they are mandated to maintain transparency and accountability by conducting extensive reporting on every dollar spent. One of the common claims made to legislators is that providers, pharmacists, and payers are unaware of the value of a 340B discount, keeping them from applying these savings to patients' out-of-pocket costs. However, this claim is false. Many 340B entities employ third-party administrators, or TPAs. These TPAs are often vertically integrated with pharmacy benefit managers and contract pharmacies, allowing providers to know the exact or approximate value of 340B revenue of a specific medication will generate while seeing the patient before the patient even reaches the pharmacy counter. Reiterating what Kathy said, the HRSA report from the top 10 340B medications from 2023, Keytruda emerges at the top of the list, suggesting that hospitals may be profiting more from Keytruda than the manufacturer without any tangible benefits being shared with patients. Despite the publicly available data on bad actors in the 340B program, these entities are not held accountable for their misuse of millions of dollars in program revenues. Overall, the agreements between contract pharmacies, TPAs, and covered entities reflect a proliferation of fees across various services and settings, With multiple for-profit entities receiving substantial financial benefit, the incentives are aligned to exert more payment pressure on covered entities, thereby diverting resources from the 340B's intended purpose of allowing covered entities to stretch scarce federal resources as far as possible. These examples only underscore a significant issue with 340B and emphasizes the urgent need for comprehensive reform. Patients should be the primary beneficiaries of healthcare programs, and it is perplexing how hospitals can make more money from certain medications without providing any tangible advantages to patients. The calls for transparency and accountability are growing as 340B becomes a central focus and more widely known among the public. The North Carolina Treasury Report was mentioned before. From the Senate Health Committee investigation to several reports have been released at the state level, they highlight how 340B has gotten off track and lost its focus on supporting vulnerable patients. In Bon Secours, Mercy Health's response to Senator Bill Cassidy's request for information, asking how 340B revenues were used, their response is, "We don't segregate revenue. Revenue is revenue." Based on written responses from BSMH and Cleveland Clinic, each generated hundreds of millions of dollars in 340B savings and revenue from the 340B program from 2018 to 2023. In their response to Chairman Cassidy, both BSMH and Cleveland Clinic explained that they do not directly pass on all savings generated from the 340B program to patients in the form of savings on healthcare expenses. When Minnesota released its first mandated financial report on the 340B drug pricing program, it provided insights into the spending, profits, and program integrity. It found there was a lack of transparency, that the Department of Health lacked transparency into how the hospitals were utilizing their 340B funds beyond community benefit obligations. More than $1 in $6 of 340B profits in Minnesota went to for-profit companies. Many of the leading specialty drugs in Minnesota have 340B discounts of more than 50% or more. And patients covered by commercial insurance and Medicare Part D are funding 340B profits by paying full price for prescriptions that 340B entities bought at a discount. All of these examples highlight the need for transparency and accountability, the urgent need to update the definition of patient and so-called community benefit to ensure the program meets its legislative intent. The lack of congressional oversight and reform have led to for-profit entities capitalizing while patients suffer the consequences. It has led to rising medical costs when hospital costs are the primary driver of anticipated and realized healthcare costs in this country. There are nearly 20 million, 1 in 12 adults, who owe medical debt. The SIP survey suggests that people in the United States owe at least $220 billion in medical debt. If Texas had passed its 340B mandate bill, it would have cost the state's HIV program millions of dollars, making the program insolvent by 2027 from loss of rebates. Unchecked, 340B has encouraged consolidation, community pharmacy closures, harms rural access, and an extraordinary example of abuse been the driving financial force of a mismanaged housing program in Los Angeles that left patients dead. Continuing on this trajectory only means one thing. Capitalism is allowed to eclipse compassion. It's the most vulnerable who suffer. The single parent deciding between medication and groceries, the senior citizen delaying care due to skyrocketing costs, and the patient who faces unnecessary barriers in accessing life-saving treatments. These stories are not isolated. They are far too common in a system that prioritizes margins over medicine. Multiple state reports and Chairman Cassidy's investigation underscore that there's a need for transparency and oversight to prevent 340 that the lack of that prevents 340B discounts from translating to better access or lower costs for patients. And Congress needs to act to bring much needed reform to the 340B program, not a patchwork of state laws and that protect the profiteering. In closing, to be clear, CANN supports a strong 340B program. We remain steadfast in our commitment to a healthcare system that works for everyone, especially those most in need. When 340B operates the way it's intended, safety net providers thrive, and vulnerable communities, their families, and individuals gain access to healthcare they otherwise might not have. It doesn't have to be this way. In this moment of such challenging policies and divided politics, I think we have the power to reimagine healthcare, one that centers humanity, dignity, and equity at its core. By prioritizing patient care over corporate gain, we invest in a future where individuals are not just surviving, but thriving, where disparities are eliminated and where healthcare is a right, not a privilege. A system that truly meets the legislative intent to stretch scarce federal resources to reach more eligible patients and provide more comprehensive care. We must promote and support policies that lead with courage and conviction, demonstrating that we value lives over ledgers. Thank you.
Thank you, Kalvin. So we have a couple of minutes, so I'm going to be very succinct, and I want your answers to be very succinct. A couple of things that have come up on the chat box is that, well, the whole purpose of 340B is for these hospitals to make margins and then pass it on as charity care to patients. So isn't that what's happening? Who wants to take that question? Erin, I see you shaking your head. So
Someone else might be able to specifically talk about data,
Okay.
but in this area where we're seeing like 340B pop up in private hospitals, they're not delivering charity care. Their numbers of charitable patients that they're working with are diminished. And I think that that data is all over the place. So I don't think that was ever the intent of 340B to help hospitals be able to deliver charitable care, other than to the individuals receiving the drugs. It's not there to pad their coffers so that they can tolerate free, people coming into their emergency rooms. There's other funding sources for that, right? And so no, I don't think, I think it's an abuse. I think that there's a loophole that people have discovered, right? And are taking advantage of it. And eventually, the money is not endless. And we're starting to see that.
Thank you, Erin. So the next one, I want Nick to comment on this because and Calvin brought it up. There is no good definition of who is, right? Who is eligible. It's the institution that becomes eligible, not necessarily patients. And there's always been the discussion that the discount should follow the patient. And so if they want to go to a community oncology center or a hospital, they can go to any one of them, they still get the discount. What are your thoughts about that?
Yeah, I think, that's the concept called follow the patient. And I think that's critical. Fundamentally, we have a lot of needs-based services in this country, right? Food stamps, for example, they are very clear. An individual needs this service. They are given it, welfare, Medicaid, etc. So we have needs-based things that follow an individual through their journeys in life. And we've identified as a country, we agree that's what's called a safety net. So why is this program not benefiting an individual directly in that way where they can pick their provider, for example? I think more fundamentally, I just want to say one thing that's been on my mind too. And, Kalvin talked a little bit about, we've all talked about this. Like, we have this program with a very good intent that is fundamentally broken. And I've seen some of the questions and chats pop up, what's the purpose of the program? What's the intent of the program? The intent of the program is not to give a hospital in Louisiana, or actually, and this happened in Florida too, a hospital in Florida, tens of millions of dollars in which to go and pad their sports programs with and do naming rights or hiring NCAA football coaches, right? The intent of this program is a charity program for nonprofit, and I put nonprofit in quotes because these are very profitable institutions. It's just the tax code. Nonprofit institutions to ostensibly provide charity care and help more patients access more care through their drug programs. And that is fundamentally not happening. And so regardless of, follow the patient, all these definitions, like, I think we all get lost in all these like sort of side stories, which is very important. We need to focus, but like, what's the purpose of the program? And is this program meeting its purpose? And that's it.
Lisa, I'll ask you a question. Consumers, besides the medical death issue that you talked about, how are they overpaying? One of the questions I get from reporters is, who cares, right? Consumers are not paying for this. This is coming out of the pocket of pharma companies and so on and so forth. Why would they care, or why would commercial payers care? Because this is not about commercial market, but why should consumers care about this beyond just the medical death issue that you've talked about?
Yeah, well, it's also resulting in higher copays, higher deductibles, higher premiums, which is something that we all care about as well. So I would argue that it absolutely impacts consumers beyond medical debt.
Lisa, and I'm going to finish up with a question for Kathy and maybe even Erin. If we are going down this road, and you guys both have talked about it, especially Kathy, you talked about, you know, business practices going out of business, are we going to be left with everybody being employed by either a hospital or by an insurance company? I mean, 10% of registered physicians right now in the United States are employed by United Healthcare. They get an Optum Rx paycheck. So are we down the road that there will not be any independent physician practices?
Not if Erin and I have anything to say.
That's right. We'll try to stand in the way, but I think that's the biggest concern. And I think the people who should be the most concerned about that are patients, right? I mean, there's just endless examples and stories and data talking about lack of efficiency, lack of efficacy for treatments, and those people getting sicker, right? So, yeah. This is supposed to be the decade of the private practitioner, and I think you do see some energy where people are leaving those bigger systems, but we'll see.
Yeah, it's unfortunate, but I mean, what Calvin has said about the access issue with patients and everything else, but the incentives are in place for big to get bigger. When you're making, Calvin mentioned this, I believe some of you other ones mentioned that the margins for these contract pharmacies, why contract pharmacies are expanding, is 13 to 16%. Dispensing fee for a Medicaid drug in most states is $10 to dispense a medicine. If you're making 16% margin on $1,000 drug, you're always going to adhere to going towards a 340B drug fill. And if they get bigger, that means they buy out the independent pharmacies. But as they get bigger, these insurance companies get bigger, and and they are going to start buying out practices and everything else. So this is why the system needs to be reformed. I want to thank everybody, all the panelists who were on. I hope you had a good way of basically giving your point of view. I want to thank the ICANN for putting this event together. And if you have any further questions, please visit the websites that were in the chat box, including the Pioneer Institute, that we have all of this data available for the state level 340B program. So thank you so much, and we'll see you guys all next time.
All right. Thank you.
Okay, are we going to be able to, Ashraf, share the presentation? That's what the question was being asked. I don't know. That's between you and the presenters, I guess.
Yes, I will ask the presenter and to share the presentation with everyone.
Okay, thank you guys. Thanks, Kalvin. Take care.